Welcome back to Mark Carney's book club. Today we're going to go through the second part of chapter 9. In the last video, we started chapter 9 and described the lead up to the COVID-19 pandemic and described how our governments were unprepared for the pandemic and a little bit of history on the government's role in preparing for public health emergencies. And he says that the situations in the US and Europe were just as bad and the attitudes of government were just as cavalier. In 2019, the World Bank estimated that low to middle income countries would need to spend less than $2 per person to improve the core capabilities mandated by the international health regulations. Twice the recommended annual investment in pandemic preparedness would have amounted to about 1 day of lost global economic output that occurred because of the inadequate measures that were taken. So states had the capacity but failed to deploy it to fulfill their duties. Why? Why did they do that? Let's see. It's because, he says, resilience was undervalued. Our brains often work against us when it comes to making the longer-term investments necessary to withstand catastrophes when they strike. Research in behavioral psychology has established that humans have a host of cognitive biases that mean we undervalue resilience. We display a present bias and discount problems and benefits that will occur in the future, preferring immediate rewards even if they are lesser in overall value. Our priorities often focus on preventing repeats of recent calamities, even if other threats are greater. So we demand increases in aircraft safety in the weeks following a crash, despite automobile accidents being a far more likely cause of deaths. He says that we all have confirmation bias and we focus on the success of previous, much smaller pandemics. The sorry history of financial crisis extends to the pandemic preparation, with people being lulled into thinking that devastating health crises are always a thing of the past. Having failed to protect their citizens from the spread of a pandemic, states have concentrated on mitigating the fallout. The complex interrelationships between the twin crises of health and economics have required authorities to weigh the estimated costs and benefits of various restrictions on economic activity and personal liberty. As they have, the crisis has helped reveal what society values. The pandemic has forced society into a series of extremely difficult value judgments. The initial months of COVID brought a wave of cost-benefit analysis on lockdown measures, as well as increased public scrutiny of how such decisions are made. And as we have seen, a fundamental challenge for cost-benefit analysis is how to convert the variables into comparable units so that the net impact of a decision can be calculated. This is particularly difficult when comparing economic costs and the impact on health and quality of life. An expected decrease in GDP comes with an associated dollar figure, but there's no immediate, obvious numerical value, monetary or otherwise, to represent a lost life. This brings up the discussion on valuing a life. He speaks about how the brilliant minds in the past had done so, and that value is based on the lost working years and compensation of somebody. Valuing lives by labor potential makes sense in instances of civil compensation or insurance, where the life in question is already over and the objective is to ensure the deceased family remains financially secure. The shortcomings of this valuation method, however, become evident as governments in the 20th century increasingly began to look to value life not to compensate for death, but to assess the desirability of preventing death from happening. In these cases, financial security and accounting costs cannot be the only factors to consider, for if they were, money should never be spent to save the lives of retirees or those permanently out of the labor force, as no strictly financial loss would be incurred by their death. Advancements in valuation of human life came in a 1968 article by Thomas Schelling, which was entitled "The Life You Save May Be Your Own." He said that questions of life saving had to be posed to those who would be affected, those who may die. He also claimed that calculations didn't need to value life, but rather the calculations needed to value the postponement of death. So the focus was on postponing not a specific death, but a statistical death. His work has gone on to form the basis of how policymakers value lives, and his term, the value of a statistical life, VSL, has become the reigning vocabulary in this space. His solution was to determine people's preferences when it came to accepting risk. He suggested looking at existing price structures and conducting surveys. So we're going to go through the methods of valuing a statistical life next. The first class of methods, revealed preference, is based on individual behavior in markets where prices reflect differences in mortality risk. In the hedonic wage approach, VSL is calculated in reference to the wage premium one receives for working in a dangerous job. As a simplified example, if the risk of death in a certain high-risk job were 1 in 10,000 and workers received 300 annually in danger pay, the VSL estimate would be $3 million. In an averting cost approach, a VSL is calculated in reference to expenditures people make, such as buying a helmet, to reduce the probability or severity of a bad outcome. In contrast, stated preference methods construct a hypothetical market for a given chance in mortality risk and ask respondents directly in surveys for their willingness to pay to reduce the risk. A contingent valuation approach typically asks the respondent for their willingness to pay for a public program that would reduce their mortality risk directly. A choice modeling approach asks respondents to make a series of choices between health risks with different characteristics and monetary costs. All the methods of valuing life have strengths and weaknesses, with different countries using different methods more regularly. This range of different methods leads to a surprising variance in the value of a statistical life across countries. An OECD survey in 2012 showed that in Canada, estimates range from 3.4 million Canadian to 9.9 million Canadian, while in the United States, the range was $1 million to $10 million. The European Commission, meanwhile, recommended the value of a statistical life should be somewhere in the range of £1 million to £2 million. And the United Kingdom's Department of Transport used the disturbingly precise figure of £1,638,390. It is worth noting that these values are not static. Government agencies adjust their VSL to account for inflation, and at least in the United States, VSL has trended upwards at a rate that rapidly exceeds inflation. In terms of people's estimation of the value of their lives, at least, America isn't just great again. It apparently has never been so great. In healthcare, it is common to employ a cost-utility analysis instead of a cost-benefit analysis, focusing on the added utility per dollar. So public health agencies and insurance companies are likely to approve a treatment if it costs less than a prescribed amount for every year of life it gives the patient. Years of life are usually adjusted for quality, so that a year of life in full health is equal to one quality-adjusted life year, QALY. But a year of life with a diagnosable mental illness experience is worth only 0.8 QALY. The impact of a health ailment on quality is determined by surveys of general population akin to the stated preference methods of VSL. As an example, the EQ5D is a questionnaire reflecting 5 dimensions: mobility, self-care, unusual activity, pain, and anxiety. Okay, so we're going to wrap up part 2 there. We're going to finish up chapter 9, going more into this discussion on how the powers that be determined the value of lives, essentially, and why Carney believes that valuing lives is very radically different from valuing consumer goods. So stay tuned for that. Follow along.